All right, I know it's late and you're getting exhausted, and I'll try and do this as painlessly as possible. Are we going from the other one? So I got involved in this area, fortunately or unfortunately, because I was asked to chair a committee that was going to look into this issue of resuscitation in pregnant women. The feeling was that although the AHA do cover it in their guidelines, it's not adequately addressed in certain areas, certainly not well highlighted, and we find ongoing problems with its implementation. So the idea behind this committee was to come up with a consensus statement, really very much because of the level of evidence, just an advisory or recommendation, by no means a guideline. So I thought this would be an easy task, and we assembled neonatology, nursing, cardiology, OB, and OB anesthesiologists, basically everyone we would consider, even ER physician, to try and come up with these guidelines. What I underestimated is trying to get consensus with experts who feel very passionate about a particular subject is no easy task. So it's been revised, re-revised, and re-revised, but we're almost there. And I just want to, before I begin, just thank Steve Lipman in particular and Sheila Cohen for the amount of work that they've put into this. Am I back onto, okay. We're flipping between things. So I don't need to remind you that there is a maternal mortality, as awful as it sounds, and unfortunately it is appearing to increase. And this is some data from California, and it's led to a lot of initiatives to try and reduce this. And it's obvious that the end result, or prior to mortality, would be an arrest situation. And that's what I'm going to be highlighting. It's estimated to occur 1 in 20 to 1 in 50,000 maternities, and the survival rate is a paltry 15%, so it's really problematic and something we can hopefully do something about it. And the idea is to prevent the situation on the left turning from that and rather having something like this and getting patients home. So I'm going to highlight certain particular references in the care of pregnant patients and CPR in the setting of pregnancy. And it is extremely difficult because you're dealing with two critically ill patients at the same time. There's the physiological change of pregnancy, and it's occurring in a setting where we are not well equipped based on lack of experience and very often equipment that we have to handle these emergencies. Like I mentioned, the AHA, while they do cover in a cursory way resuscitation of pregnant women, it's not highlighted adequately in a lot of ACLS courses, and there are a number of institutional issues that we have to deal with. So don't worry about the slide, it's very busy, but this is the AHA guideline. The reference is in your handout, and this is how it is covered. We're going to go through specific areas and highlighting certain areas. The content within is reasonable, but the implementation, like I say, is not. So starting off with something as simple when an arrest occurs, calling for help. And in simulations that are done at Stanford, shows that time and time again, neonatal teams are not called. So if you are implementing a system where you can call for help, it is critically important to have an OB-specific code that goes out, and all the various parties get involved, in particular calling for neonatal teams. And then staff access being a problem because you're getting staff from various settings. It could occur in the ER, it can occur on labor and delivery, you need to get staff in, or your own staff out to remote settings, and very often with security settings, staff cannot get them into the area to help out. So this is something, while it sounds like a simple concept of calling for help, there's a lot of institutional difficulties in implementing something as simple as that. There is obviously emphasis towards basic life support. I think when we work in a hospital, we're too worried about rushing into ACLS and forget that basic life support is what makes a difference. And for basic life support to be successful in this setting, it is key to do left uterine displacement. We recommend it after 20 weeks. The evidence would suggest, although it may occur much early on in pregnancy, it is impractical, let's say, at 12 weeks to be able to do so. So the recommendation from the data would suggest that from 20 weeks onwards. Now, you don't have to rush to patients' notes to work out if they're 20 weeks. If the uterus looks like it's outside the pelvis, around the umbilicus, implement left uterine displacement. And there's 3 pictures here, and these are what recommended positions to try and help left uterine displacement. And our feeling is the position on the right, so tilting the bed or the backboard, is impractical, and it can also affect the efficacy of chest compression. So the recommendation is for manual displacement from either side, and the 2 techniques being outlined here, and there's a reference to this if you need it. With the change in the AHA guidelines, there was emphasis towards chest compressions over airway breathing and circulation, and change around to CAB. And although, yes, we are worried about pregnant patients' airways and the different physiological changes, we'd still recommend the same emphasis on chest compressions followed as the AHA recommend, with emphasis of pushing hard and fast to limit the interruptions, both checking before and no checking afterwards, and using the same CPR that is recommended by the AHA with the 32 rule in unintubated or continuous CPR throughout. What we've noticed is that providers get very tired quickly. I've personally participated in these drills. It's very tiring doing CPR. I have a system in place that providers can change every 2 minutes. And the only modification on chest compressions that is required is to move the hand position about 2 or 3 centimeters higher because of the displacement that occurs with a term pregnant woman. Now, we always think of capnography as a device that is able to measure whether or not you've able to intubate someone and showing CO2 for tube placement. But there's actually good evidence in a resuscitation setting that it can show a few things. Firstly, how effective your chest compressions are, as well as the likelihood of return of spontaneous circulation. So if you keep levels greater than 10, or a rising level is predictive of these. But I appreciate that it is not widely available in most institutions, in particular in the labor and delivery setting. So it is not an excuse not to use it. You should try and get it, especially if you're updating your resuscitation carts. The new defibrillators actually can have a capnography embedded in it. You should not delay good chest compressions to get it, but if you have the modality or if the rest occurs in a place that you can utilize it, it is something that is worth using as a monitor. We've emphasized intravenous access at several of these talks, in particular the hemorrhage talks, and this is obviously an area that you have to get intravenous access. I'll just emphasize 2 things in this setting. Number 1 is try and get access above the diaphragm. If you're going to use interosseous placement or ultrasound guidance in difficult intravenous access patients, try and do it above the diaphragm so the drugs can get into the area that they most are required. Airway management is no different to what Maya Suresh has been talking about, with a few little caveats. In this area, very often you're dealing with providers who do not have experience, especially the first responders, in airway management. So we want to emphasize that first responders maintain simple maneuvers to maximize oxygenation. So just jaw thrust and bag masking, and not to make attempts, and certainly not to interrupt chest compressions with trying to look for more advanced airway devices. With experienced operators, it really follows whatever protocols, and I'll show you just an example of what we've come up with, but the primary objective always has to be on oxygenation ventilation. The AHA guidelines, interestingly, do not say that cricoid is necessary for, to apply cricoid in the non-pregnant patient. There's no specific recommendations in a pregnant patient, but our feeling, and we emphasize the fact that if your priority is ventilation, oxygenation, and that cricoid is dubious at best, that it actually works to prevent aspiration, our advice would be not to utilize it, especially if it is affecting your ability to ventilate and oxygenate a patient. So this is an algorithm we've come up with. It's slightly tweaked from what's in your handout and may get tweaked a little further. It is not that there is a right way of doing it, but we want to take our tools that people can utilize in their own institution and get people thinking, how are we going to manage an airway, firstly with responders that aren't experienced airway handlers, and then how should we sequentially follow and give advice towards how to manage difficult airways. We try to simplify it as much as possible, and this is to take to institutions to implement at your own institution what works best within your setting. So part of the resuscitation and key to get early defibrillation, and this is emphasized in the AHA guidelines, but very often is not well implemented. So as soon as an arrest occurs, there has to be orders to get a defibrillator. Obviously, if it's immediately available and attached, you should use it as soon as possible. And in the simulation work done at Stanford, AED in the setting of labor and delivery is the most practical defibrillator. You're dealing with a lot of staff that are not experienced with reading rhythms and responding to rhythms, and AED does a lot better than standard defibrillation. So that would be our recommendation. The other additional bonus with AEDs, if you utilize pads, is you free up hands. You can do various other stuff in addition to monitoring electrical cardiac activity in between shocks. And it is, like I say, a strong emphasis to consider AEDs if you are replacing your current defibrillators. There's a lot of controversy as to how to handle fetal monitoring, and I'll just emphasize that when it comes to fetal monitoring, it is not important to monitor the fetus in this situation. All the emphasis should be on the mother and resuscitating the mother, so there is no point even reading or looking into any fetal trace. The problem is you may have external devices which can affect the conduct of resuscitation. In particular, if the patient's going to go for perimortem cesarean delivery, it may be prudent to actually remove it. And there's concern with FSCs if you're going to use defibrillation and current arcing and burning. And I'll emphasize the fact that this is more theoretical, and do not defibrillate patients because monitors are attached. You can detach it from your machine. I'll deal with the consequences of burns or arcing later, but it hasn't been well elucidated, and we don't want to detract from good resuscitation and defibrillation. Resuscitative drugs do not need to be altered. While there are a number of physiological changes that would affect the behavior of drugs in a pregnant patient, this is not well studied in a patient who's arrested, and we would strongly recommend no alterations in both drugs that you use or dosages. If you suspect a local anesthetic toxicity, utilize the lipid emulsion protocols that are widely available, and ASRA has released one such guidelines, but there's various out there. And to consider how certain drugs like oxytocin can be cardiovascularly problematic, and there was a case in the United Kingdom with a 10-unit bolus of oxytocin after cesarean that actually induced cardiac arrest. So be very careful with your dose of oxytocin if you're using it in this setting. Once again, a busy slide which comes from AHA. It's just to remind you nothing changes with resuscitation. So forget that they're pregnant and continue doing exactly what you'd normally do, managing your VF or VT and your asystole and your PEA in the same way as you would normally do. The one critical difference in this setting, and it's one thing that is very often not appreciated, and you see time and time again when you review cases, is that perimortem cesarean delivery is not implemented in a timely fashion. In fact, very often, cesarean deliveries are reserved for removing the baby long after resuscitation has begun. So the advice and the recommendations, and I'll go into a little bit of why we recommend it, is to consider making an incision in 4 minutes and to perform delivery within 5 minutes of the arrest. You perform it, as for left uterine displacements, once you're 20 weeks and beyond. And the only way you will be able to accomplish this is by thinking about it immediately, planning for it, and starting to work on it the second the arrest occurs. So why do we recommend perimortem cesarean delivery? Well, normally normal CPR is only going to give you about 30% of your cardiac output. If you add the problems with aortocaval compression and a term parturient, which decreases it further, you're probably only getting about a 10% cardiac output, even with good CPR. And once you can relieve that and improve the pulmonary dynamics of removing the baby, it can, at least has a potential to improve the situation. So that's the theory. What about the practice? Now, I'll emphasize that Vern Katz, who's actually on this consensus committee and been looking into it, was the first to propose it about 20, 30 years ago, based on animal data as well as some case reports. And he re-looked at it 20 years after he suggested this change. There have been lots of case reports showing where you have a woman who technically is dead, where the cesarean delivery is then performed, sudden return of spontaneous circulation. So when Vern Katz looked at it, and there were 38 cases in this 20-year period, found that 12 of the 20 cases improved, and return of spontaneous circulation occurred after the perimortem cesarean delivery. And recently, Sharon Einov looked at her data back in Israel, found that a third of the patients who had cesarean delivery, and about 87 actually were able to have it done, benefited from it. And the key is you do not create harm, and it's a maneuver that experts would recommend utilizing in this setting. And interestingly, it is to save the mom's life. It is not to save the baby's life. A secondary gain from this perimortem cesarean delivery, or timely perimortem cesarean delivery, is that by delivering the baby early, you improve neurological outcome in the baby, which is obvious. And the graph on the left from AFE registries that Clark looked at, and the graph on the right from Vern Katz's work looking at neonatal outcomes. The logistics of doing it are very complicated, and unless you've thought about it and done team training to be able to accomplish that, it is highly unlikely you're going to do it. And even in an ideal setting, and I'll show you data, it is extremely difficult to attain the 5 minutes, and it is not a standard, it is an aim, 5 minutes. To actually do a cesarean delivery, you need nothing more than a scalpel. You don't have to worry about sterility. There's controversy as to the best way of cutting the baby. You don't have to worry about this. The teaching has always been vertical incision, but OBs are so much more astute with fan and steel incision, because that's what they do all the time, that there is a desire amongst OBs to educate their residents to do whichever technique they feel most comfortable with in that setting. And that review that I mentioned that Sharon Einov did was interesting, because even in a really good setting, this is where arrests are witnessed within a hospital setting, very few were able to do it within the 5 minutes time. So in this particular review, only 4 out of 76, which is not surprising. And they felt like 10 minutes is reasonable, and actually the 10-minute outcome showed reasonable benefit. So there's controversy as is 5 or 10 the desired amount. But my concern with moving it to 10 minutes is this is always going to get stretched. So once again, aim for 5. Realistically, it is extremely difficult to do, and I'll show you evidence of this. So at our institution, we were running simulations because there was suggestions that the best way to do these perimortem cesarean deliveries are to rush patients back to the operating room to do this. And we felt like logistically that's very difficult, and it's going to lead to extensive delays. So in a team simulator training, one group of teams were randomized to stay exactly where they were during the rest, and the others said they had to move to the operating room. And they knew about the scenario. It was a simulated scenario, and the skin incision model is obviously a lot quicker to do than you would in the real world. And despite that, well, firstly, there was a big difference, as you can see on the slide, of 4.5 minutes in the group that actually did it in that site of arrest versus close to 8 minutes in those that moved to the operating room. And only 57% of the laboring room patients, so those that did it at the site, were able to accomplish it within 5 minutes. And very few, only 14% of those that moved to the operating room. And you may say, well, the problem is that you've got to move the patient, it takes a long time to move it. It only took 30 seconds to move the patient to the operating room. It's the logistic that's attached to moving the patient out of the room, monitors being applied, taking it off, reapplied, and all the other problems that are associated with it. So our strong recommendation is not to move patients and to do a perimortem cesarean section at the site that they arrest, wherever that will be. And one other evidence why it's not a good idea to move patients, also based on simulator work done at Stanford, where we artificially created a situation where one of us had to run around for 2 minutes doing CPR, which is sort of an interesting scenario, like how do you do CPR on the move? Do you jump on the gurney, run alongside the gurney? It was fun just watching people. One of our labor nurses nearly had a cardiac arrest doing it, but that's besides the point. But if you look at the graph on the left, in red, those are the group that was doing CPR and then were told to move for the 2 minutes, so pretending to transport to the operating room. And then the phase 3 was when they were back stationary again. And you can see a clear decrement on the ability to do CPR on the move. And the graph on the left showing the ability to ventilate the mannequins. and there was a decrement in the tidal volumes that you were able to generate. So these are mannequins that can actually measure how effective your chest compressions and your ventilation are. So more evidence for not moving a patient. As I move along, you've obviously got to be, during an arrest, be looking for potential causes. And we came up with this checklist. There's no perfect list, but the reason behind it is there was universal dislike for the AHA bow chops. It sounds more like a type of meat cut rather than a good way of following what to do, and notoriously no one ever knows what it stands for. So we try to simplify it, but it really makes no difference what checklist you do, as long as you're familiar with it, and as long as you have something at the point of care that team leaders can work through to try and look at potential contributing causes. And there's a whole list. You'll notice under G, general causes, which is the H's and T's, which I can highlight in a little bit more detail. So the problem with the 5 H's and 5 T's in an OB setting, it is not really ones that are significant contributors towards the arrest in this situation. So using your standard contributory causes is not ideal. I would emphasize having an OB-specific list of causes to go through. Well, your problem doesn't end when the arrest is occurring, but you've got to start thinking, what am I going to do afterwards? And the key with post-cardiac arrest care is that you don't want to cause either further deterioration or another arrest situation. So there's a lot of things described to maybe improve the situation. There's case reports of ECMO being applied and cardiac bypass in the setting. Very difficult to accomplish in a timely fashion. But I just want to highlight therapeutic hypothermia. And it's shown in non-pregnant patients to be very useful in decreasing deterioration of both neural and cardiac tissue. The problem in an OB setting is it's not well studied. There's a few case reports of patients where this was utilized. We've got to have two concerns, one of which is hemorrhage, which it may aggravate, and also the potential fetal impact of hypothermia. So this is a real judgment call, but absolutely it should be in your differential to consider utilizing. It's certainly been shown to be beneficial outside the pregnant patient setting. Well, there's no point having all that theory unless you have good implementation strategies. And I hope for those of you who haven't got good implementation strategies at your hospital, you take some of this back and start with education. A point of care checklist or a cognitive aids is not going to solve the problem just having it here. And Jill Hilton, who's somewhere in the audience, recently was looking at that, where a group knew they had a cognitive aid, they knew where it was, and no one picked it up to look at it. And the problem is, unless you're familiar with it, you're not going to use it in an emergent situation. So it's not only put the devices there and put the equipment and the cognitive aid, but make sure people are familiar and educated in how to use it. And it has to be everywhere where you think is a high-risk area, in particular the ER and then out-of-sight places, potentially radiology suites. So think through where you may require all this. This is a point of care checklist, which is actually in your handouts. It's been tweaked a little bit since then, and it's once again just coming up with something that can be used at the point of care to go through it. These will all be eventually available on the SOAP website, and I'm happy to send anyone who wants a lot of these. This is one point of care checklist. Larry Chu, who is right in front of me, or somewhere has run away, he's the guy responsible for all the filming, and he has, with collaboration from Stanford and various other institutions, has a website called Anesthesia Illustrated. So all these lectures that are from Sol Schneider are going to be on the web, freely available for anyone in the world to download. And it's quite amazing how this is utilized, this information. But he's also produced these cognitive aids for resuscitation that are freely available. Have a look at them, download them, and if you feel they are useful in your institution, by all means utilize it. But it's a website that you should go and look. It's non-profit, everything's free, and it's really just to spread the word and help with education. I'm not going to go too much in key behavioral issues, but until you run simulations, you'll have no appreciation for all the things that go wrong. And like I point back out to Jill Hilton, who does a lot of this work. She can talk to how poor communication is, in particular seeing open air commands where you just yell out stuff and don't get the feedback or closing the loop, and the poor leadership. It's very complicated because you will have an anesthesiologist, OB, neonatologist, and there's various leaders, and you need a good system in place where all of this is well coordinated. And you'll only realize these key behavioral issues when you actually run team-based training within your institution. How often you should be doing this, if you should have an unannounced or announced what sort of metrics to use when you are looking at this is all things that we're not sure about. The most important thing is you do create some implementation strategy and some other strategy to look at ongoing quality assurance and to learn from little things that may come up. And just as an example of this, the first time we ran a simulation at Stanford with perimortem cesarean delivery, we realized that our cesarean section kit, the pack that we do surgery with, goes for autoclaving, and the scalpel is a plastic scalpel that usually gets added to the kit, so it wasn't present. So we had our C-section kit without a scalpel. So unless you run all of these things and you get the logistics and the problems that may develop, it's very difficult to be able to avoid these. Last few slides is to deal with equipment. I've emphasized the use of AED in this setting. There's a whole list of equipment that you've got to work through, and like I mentioned before, make sure it is in the correct setting that you may have these arrests. And it's not just the mom's equipment that you require, but think through the perimortem cesarean delivery, how to do it. You really just need a scalpel, but if you can have the other devices ready, especially when you get return of spontaneous circulation, you may have significant hemorrhage, and the ability for hemostasis is necessary then. And remember, there's a baby being born, and resuscitation for the baby is required, so you have to think through all of these along the way. So I've gone through our basic consensus of going through this. If you've learned nothing from it, that'll please me no end, because it means the word is out there. But a recurring problem we see is that this is not out there. So go and talk to your colleagues at your hospital and try and spread the word. Remember, call for help and make sure that this is implemented well and that you check that the system works. It must be an OB-specific call for help, getting neonatologists on board. Basic life support with left uterine displacement and early defibrillation, as AHA emphasized. And the modifications are minor, with one major exception in the resuscitation, which is the perimortem cesarean delivery. Aim for 5 minutes. It makes an impact on the mom as well as the baby's life. An emphasis that this has to be checked through, because you won't be able to do it when the actual arrest occurs. So I hope I can take some heat off you with what I've said, and good luck with implementing these strategies at your hospital if you don't already. Thank you.